Model that you're proposing, especially the checking on the transition from elementary to middle school. For the record, that's when I started to get straight Fs all the way through high school, and the same thing happened for my sister. And yeah, that's such a pivotal time, and I just appreciate the idea that you're going to try to counteract this long downstream outcome by going way upstream. So thank you. And I don't really have a question. I
would just say that it's been difficult because there's so much focus on the middle.
Oh yeah, they should work, but you'll have to still project a little bit.
So there's a lot of interventions based on middle school because of the transition and the issues kids face. There wasn't a lot on the, as I'm calling middle childhood, this kind of earlier period of 3rd to 5th grade, where kids are still at risk for a lot of issues that kind of get lost if you're just focusing on middle school kids. So it's important to think about elementary school kids in terms of interventions for health disparities.
There was a question here, and I'll come back up there. Yeah.
Hi, Noah Seixas from Public Health. For Dr. Dahl, the endometrial cancer story is very compelling, but you do a very interesting thing, which is you look at the clinical care opportunities and how they impact the disparity. But you take out of the equation the supposedly biological characteristic of the histology at the beginning. You don't want to look at that. But I wonder if you have thought about, or if other people have thought about, risk factors for the histology and whether those might be environmentally determined as well.
Yeah, thank you for the question. So for the sake of time, I significantly cut down my talk, but so I would say I'm very interested in the histology piece. My point is that even within those aggressive histologies, Black women still are dying much more often than white women, and actually within those histologies, the mortality gap is worse. And so that is part of where my focus goes to the systems of care. And I'm very interested in using the Anderson model of patient delay, which actually focuses on these pre-health interactions among patients and their family members and friends about how they kind of self-manage symptoms. But anyway, back to your question though, there has been some work looking at the potential environmental risk factors for endometrial cancer in general. I'm not as well versed as if there's been as much about the specific higher risk histologies. I think that there's probably a lot there in epigenetics and stress and tumor biology. And the other thing about the high risk, and again, cut out for the sake of the talk, is that part of that is just progression of aggressiveness of the tumor, which happens over time. So there's grade 1, grade 2, and grade 3 tumors. And the bottom line is if you don't ever treat your grade 1 tumor, it has a high likelihood of turning into a grade 3 tumor. So we have, in our field, what we have done is collapsed these concepts into purely biological concepts, like, oh, you just have a grade 3 tumor, you were unlucky. And I think we need to bring back the environmental influences of, well, perhaps because you've been bleeding for 4 years. So I do agree with you.
Okay, Crystal, a question, and then.
When you had mentioned that talking about getting communities involved in dissemination of disparities research, I was wondering if you could speak more about that, or perhaps give some examples of community involvement.
Sure. I'm actually, as an epidemiologist, we're very, very good at, what you're talking about, really documenting differences, projecting more, documenting differences, and so really wanting to be more involved in what was mentioned earlier in the panel, this community-based participatory research principles. And so I've had the opportunity to partner with African American breast cancer survivors to actually implement, and that's actually how I got to screening as an issue. That was an identified need within the community that they are recognizing and wanting to address. I initially came to this from an obesity perspective. And in working with the community, realizing, actually, no, that's not what we want to work on. We want to work on screening. We know that women in our community are not being screened at the same rates as white women. And so we're working on an intervention within faith communities to be able to promote screening among African American women. And so I think it's really going back to that humility piece. You know, as researchers, we all kind of have our agenda. Being able to set that aside and really to speak to the needs that are being voiced by the community, I think that's really key. And that's, but recognizing that level of awareness or that kind of value among people varies, or among the research community varies, and especially the history within the medical field and within nursing and within health sciences in general, that hasn't been a priority. And it needs to be.
Thanks so much for all of your presentations. This has just been such a rich panel. Dr. Barrington, I have a question for you. So there's debate about the age at which women should start mammography screening for breast cancer. And when I hear about your work on screening and racial disparities, like, what is your perspective on that debate, and what does it miss?
That's a really great question, because I think, speaking.
What's the question?
The
Oh,
question
sorry, my bad.
really is about when to start screening. The issue with especially breast cancer and even prostate cancer and colorectal cancer, this idea that we're seeing these differences in the aggressiveness of tumors, and people noting that, is it really that African Americans are getting a different type of cancer, or is it that African Americans are having later stage cancer because it's being diagnosed later? And so really needing to emphasize this need for early detection, I think, is a priority. Not to say that the differences in tumor biology are not there. I think at this point we are not sure, so really needing to account for both. But the screening recommendations is a huge thing for the lay public, and in working with the survivors that I'm working with, it was interesting, the training that we gave, that Cancer Preventive Task Force recommendations changed the month after we gave the training about what to communicate about when you need to be screened. And, and what does that mean in relation to that African American women are being diagnosed at younger age? So there's something going on there. So what I have been, I've been hedging bets, and, I think there are different organizations like ASCO, the American Society for Clinical Oncology. There are different recommendations, American Cancer Society, who are acknowledging that, yes, we are seeing that there's differences with respect to age and onset, which may indicate that there's some biologic differences going on, but also can't rule out that there is just this timing issue. So we're really emphasizing, for women to have those conversations with their physicians, to be armed with that knowledge, and to have that shared decision making with respect to when to enter into the screening paradigm.
Just to add something to that, endometrial cancer it's not screenable, but it's not screenable, but it's early detectable is how I like to call it, meaning that you have an early symptom, and with prompt recognition of that, generally speaking, you can be diagnosed in early stages. But I think what is common is just like our healthcare system structure is built for the majority population, our screening guidelines are based on the majority outcomes. So how I see that in endometrial cancer is that the guidelines for the workup are very casual, because ultimately they're made for people who kind of recognize the symptom, can get into healthcare, will be taken seriously by their provider, and so they don't need to kind of go into the detail of what you should do and how quickly you should do it, and those kinds of things. So I think about that in terms of precision medicine initiatives, et cetera. Just like our healthcare structure is not built for minority populations or disadvantaged populations, neither are our screening guidelines.
And that's a huge point. They're primarily based on data sets of white people.
Yeah.
So that is what I communicate to my partners, is that these recommendations are coming from data that is not representing you. So
Question, oh, sorry. Dang, Sarah, sorry, and then
Hi. My question, I guess you could all speak to this. I'm wondering, and this is not to be critical because I've been trained in epidemiology too, and I'm interested in understanding causes of causes, but a lot of your work is trying to understand what is leading to these disparities, and frequently when we get to that, we realize that it's something that we sort of already know from a normative perspective we should be intervening on. And like, it's not a big surprise that screening rates are different, and maybe we should be doing something to address that. So I'm wondering how you see your work as fitting in, and if you have had success in sort of getting the message out about, look, if we were able to actually in a perfect world change this is what it would look like, even when we already know from a normative perspective, like, if all things being equal, this would already be this way, and we haven't had the political will to do it. Does that question sort of make sense?
Yeah, I think so. And I think, we're starting to see more studies that are taking that approach. That are really,
Can you be a little louder? I'm sorry.
yeah. We're really, I think, seeing in the field that we're starting to look at the issue in that way. So evaluating to what degree, if we were to, and I think you just presented that with your slides as well, and I did it in a different way. To what degree can we impact this disparity if we were to act? So I think the conversation is moving in that direction.
Yeah, I would just caution that perhaps the idea that we know we should be doing something is not universal. I don't feel where that would be the case. And so I think that there's a real function of the focus on biology and genetics as working against other things that we could be working on. And so I don't know the impact of what I presented because it literally was just published like 3 weeks ago, but I do think that is still important to try to reframe the conversation, because ultimately we do have to have common will. Like it is not just going to be us. And so I do still think that there's a role in trying to make that argument loudly.
Mm-hmm. Absolutely.
I'll do somebody in the back.
So, with all the research and information that you now have and all the contributing factors over the years, are you at all trying to develop, or is there in development now, an immunization such as the HPV that we have? I mean, before more, severe cases of all realms of cancer, because we haven't had, is there anything in development now? And especially with your point being that the well women checkups now have expanded. They used to be every year, annually, now then they went biannually, now they're going out more. So if we can, at the early interventions, take immunizations more seriously and maybe focus some funding on some for different types of cancers for, not just ovarian, all the different types, there's so many out there, that might be a prevention, such as like we diagnose the HPV.
I'm sorry, before you respond to that, Amelia, I know you had a comment regarding the research that provides information about the necessity of, for example, screening for ameliorating disparities.
And I was just going to say, in terms of adverse birth outcomes, I'm tired of looking at the facts that disparities continue to exist over time. The Black infants that
They can't hear. So you come up there. Sorry.
I said over time, I'm tired of looking at disparities across time not changing. I'm tired of the idea that Black infants aren't important. So kind of doing the work beyond finding the answer is where I am right now. And I think there's a lot of people who are looking for that as well. So how do we deal with it? Hopefully going upstream in childhood will be part of the answer.
All right, I'm so sorry now. Sorry about that.
So I think to kind of address your question, I think it's tricky because with breast cancer, for instance, there isn't, with cervical cancer, HPV has been identified as a huge primary risk factor for the disease, whereas with breast cancer, we just don't have that. With most cancers, we don't have that. So, finding really early detection is like the next best thing, I think.
Okay. I'm gonna go here, then here, then here. Is that good? We have time, so we're good. Okay, yeah.
My question is for Amelia. So from what I understand, there's a connection between bacterial vaginosis and preterm birth, and that it's also something where by race women differ in their vaginal microbiomes. So I'm wondering if that's any part of your intervention or something that you considered.
Can you also just kind of briefly repeat the question? Just like the okay. Yeah, you should come up here.
I'm getting a workout today. Yeah, at some point in time, I used to think about maternal infections as explanatory in terms of preterm birth. But at this point, we haven't included that into our evaluation or into our intervention. I think we have the expectation that if we address stressors and Black women's response to stressors, that contributes to increased rates of BV, then perhaps we can mitigate the effect. So we're not explicitly going after the biological explanation, but I think we're taking a more holistic kind of stress processes approach, which we hope will have an impact on that.
I'm so sorry. That's fine. They want to hear you. They want to hear your insight. Okay.
My name is Aaron Forley. I teach narrative medicine and medical humanities at Washington State University. So I'm kind of infiltrating. Y'all really up to it. I'm a associate professor out there in the English department. So I teach narrative medicine, medical humanities, and I teach African American literature and folklore. And so my question is for Dr. Dahl. Absolutely. And so here's a question. I'm curious that you talk about addressing the science and what's going in terms of what's going on with the science, in terms of how women are how Black women are thought about in scientific reports and so forth. But one of the things that you also pointed out is that there are myths on both sides. And so I get what you're doing in terms of addressing the science, but what I'm very curious about what you are doing, or have you thought about, or what's worked into your study in terms of addressing the myths that Black women hold about menopause.
Yes, thank you. So that is a big part. So that was the aim too. I ran through at the end there, but so part of my am I not
just a little bit more. Sorry.
And there's distrust, yes.
And so that is definitely a big piece, I think, of this problem. And so I'm starting with talking with women about Black women about what they think around menopause and bleeding. And what the knowledge and what the myths are. So the quotes that I put up again were from lay conversations. This has not been studied empirically, so I'm interested in doing that. And I think I have to start there to understand it. And then the question then becomes around how do we then address and educate or re-educate around what is true, and how do we start to push back against those myths. I actually think the breast literature, because it's been going on a lot longer, has a lot of examples of this in terms of the importance of screening and early detection and mammography, and now the community groups in breast cancer, African American breast cancer survivors, are pushing for mammography, which I would say was not necessarily the case 30 or 40 years ago, when there was still distrust around, what's that machine, what's it going to do to me. So I think we have to do the same work in endometrial cancer, and I fully expect that it's going to take time to do that. But it starts just with eliciting what those myths are. But I would also add, kind of going back to what Tim was talking about, where we have to also recognize where do the myths come from? What did we tell women about their different reproduction? What are the messages that women receive? And just as being a student of OBGYN, the racialized myths around Black women, and I would hear, an attending told me, Black teenagers are just made to give birth. Wow. They never tear. This is real. So I think that
when we, kind of going back to, are we really talking about a community distrusting or having a rational reaction? We have taught Black women about their reproduction and what we expect of it. We've taught them that it's normal to bleed and bleed heavily and need blood transfusions. We've taught them these things that are wrong. And so, yes, I want to hear what that sounds like now in 2017, but I also recognize that the story came from us. And so we need to re-educate ourselves as well as the community.
So Wendy, I applaud your work for all kinds of reasons, but I was also really interested in the cardiovascular differences. And I am curious if you have given any thought to the treatment options, because as you may know, one of the primary chemotherapy drugs that's used in breast cancer has negative consequences for long-term heart disease, including developing congestive heart failure. So it makes me really wonder if we've got yet another double whammy going on, where if women are coming in later, so they have, they're kind of at risk for more aggressive treatment, they're going to go for whatever is out there to sort of get the cancer under control without really thinking about the bigger picture per se, because I'm a breast cancer survivor, and I remember that conversation was about that fast. Oh yeah, you look great, go ahead, we're going to do this, and that was it. And now, several years later, I'm starting to wonder why I have heart disease going on. And so I do wonder, in terms of both a consent point of view, also a risk point of view, if women are coming in with risk factors at baseline, what is being done around that treatment conversation? Because, at the end of the day, if we treat cancers like crazy and they go away, but we kill them for other reasons, we sort of miss the point. And I think oncology gets very narrow in its thinking. I was responsible for some of the data that Crystal used, and it was important to note that all of those 9 diagnoses are single diagnoses. Those were ones we could find where that was the only ICD-9 code. And what we see is that when you start having 2 and 3 diagnoses together, everything changes. It gets a lot worse, a lot faster. And I keep thinking, oncology keeps thinking about this as cancer. And, we aren't starting to think about this as whole people, and everybody's context about these environments, the soups we're in, the epigenetic exposures perinatally, cross-generationally, all these things. And not to make this worse, but to make us conscious that when we're talking about treatment options, they also may not be the same, and the consequences might be really different. And so what kinds of conversations we might be having with people, because you hear, we're going to knock this out of the park, we're going to do everything important to get your cancer under control, and if you die of something else, well, that's the cardiologist's problem, that's not my problem.
That's an excellent point, and I have to say that the field of evaluating cardiotoxicity to these cancer treatments is emerging, and that is something I'm actually partnering with another investigator on to look at how that works within the women in WHI. And with respect to my next steps for evaluating that disparity in the CVD-specific mortality, treatment is absolutely one of those considerations.
Thank you. Did anybody else have anything to respond to that? Okay. I'm going to go here and then I'll sorry, yes. You don't have a name tag, so I can't say
I
it.
don't know. I'm Alvaro from School of Public Health. Thank you very much for this rich conversation. So Dr. Dahl, you showed that AJPH commentary that reminded me of the instruction for authors that AJPH has right now, which actually explicitly says, if you are reporting on variable rates, you should say why you collected it and what were you doing with it, what was your plan with the variable rates. So that reminds me of the really great point that Wendy mentioned about the unintentional perpetuation of some of these stereotypes that we talked about. A couple of weeks ago, JAMA published an article about how to report on sex and gender, and they recommended Table 1, when you describe your study population, do mention sex, do mention gender, and if you can, actually look at the associations by gender or by sex. So my question for you is, do you recommend such exercise or practice when it comes to variable rates in your research? Collecting it and then stratifying by it, maybe looking at it as a confounder or a modifier. And then what do you do with the point that Wendy mentioned, which is if you're going to stratify by race and look at these associations of race, how do you balance that against the trade-off between trying to decipher disparities versus actually reinforcing some of these stereotypes too. Does that make sense?
Amelia, do you want first? Sorry, go ahead. Sorry, I'm just. It doesn't matter.
Yeah, I think I understand your question. I think the way I would answer that would go back to a slide, the point that Wendy made on an early slide, or maybe a late one, about one solution to all of this is to get rid of the social construct of race and how that's unlikely. And so I think that in terms of the question of whether do we look at it or not, to me, the cat is a little out of the bag on that, and that it's already a part of our medical literature. It's a part of the way we classify people. It's a part of the way we treat people. And so the idea that you can just stop looking at it, I don't think gets us any further along the way of action. I do agree that right now I see it as a quality problem, in that I would say in medicine, there's just really little knowledge of the rich academic work around race as a social construct. This concept is foreign. And so what happens is race as a covariate is treated like age, is treated like whether you have Medicaid insurance. I mean, it's just treated as like just this single point that doesn't have any confluence with anything else. Even very simple things like testing for collinearity and what are you adjusting for in your model, and might you be over adjusting because every single person on Medicaid is also black. Things like that literally are not commonplace. And so I think what AJPH is getting at, which I do agree with, is if you're going to have race, you should be able to discuss intelligently and with evidence what is your definition of race you're using, how did you conceptualize it in terms of your modeling and what you chose to adjust for, and to what end? Are you trying to detect the absolute difference? Are you trying to understand causes? But I wouldn't argue for eliminating measuring it. I just think we need to be more thoughtful about it, because right now it's very cavalier in the way that it's in the majority, I think, of medical studies.
And I would go on to say, because I think that's an excellent point, and it kind of speaks to this opening up these conversations about race and what it means, and not being afraid to do that, because especially in education, when we are talking about race, that's a great point. Just treating it almost as a throwaway variable. Not having the opportunity to really be intentional about the interpretation given what the other factors are in your model, because that changes what that race coefficient means. So educating researchers, educating clinicians who are reading the evidence that we are generating about how to interpret these associations, I think that's the key, and I think that's probably what you're getting at too. Yeah. To acknowledge that we need to have more frank, open, and courageous conversations about race and the implications of race in healthcare and in health outcomes. And I think in this room, it's kind of speaking to what you said, Kemi, we think it's pretty commonplace because we're all here, we're all talking about it, but it's really not. Yeah.
Do you want to say anything about it?
Deconstruct race.
Yeah.
Other questions? Oh, yeah. Oh, sorry, I forgot.
Hi, Genevieve again, School of Medicine. I think implicit in all of your stories, but amplified most from your sharing, is my concern for pipeline. I mean, your story just highlighted to me how comfortable is a person of color, a woman, in seeking oncological care in the context of something that might be normalized in their own familial and social community perceptions, and then breaking that norm and then needing to seek it out in the context of someone who is very different from themselves. I am also struck, secondly, by the fact that if not for you, nobody might be looking at this. And that is terrifying to me. I mean, really, you have presented data points that, I mean, I don't think in any way you were trying to toot your own horn. You were just acknowledging that the paucity of the pervasive misunderstanding in your own area of specialty. How do we do something different about this? How do we encourage our students of color to pursue? I mean, we have many wonderful students in my school And because of their inherent interest in social justice, often go into primary care, which is my love in my home, you know, in medicine. But I think also it speaks to why it's so important for folks to go into subspecialty care and research, which I also think there is a paucity there. So maybe, Paul, you can maybe speak a little to that.
Sorry. Okay, fine. I feel like I've been talking a lot. I don't know. I think that's a big question. I would say that I agree with the point about primary care, and I do feel like somewhat of a pariah in medical spaces because of the emphasis and the importance of primary care that I acknowledge in the general public's health and well-being. And the fact that actually the fact that students of color often go into primary care is kind of touted as this is another reason why we should recruit students of color because they're more likely to go into primary care and you need more primary care. And I hear all that and it's true, but we need physicians of color in subspecialties because of what I presented. And so I would say that I don't want that argument to be lost. But the other thing I would say is that in some ways, going into these subspecialties, at least for me, I would say, as a survival mechanism, I had to start being agnostic to these issues to get through my training, and to going back to that expectation that I was talking about at the very beginning of the day, and how you're evaluated and what is important in the specialty. It's almost like I had to take a mental break from all of this stuff we're talking about to get through, to excel, to be seen as doing well, a great surgeon, etc., and then come back to it. And that is not necessarily an easy journey to tell a student they should go on or anything. And so I mean, to be very personal, like I'm kind of glad I didn't read Angela Davis's book until 2 years ago, because if I read it when I was a student, I might have just not even gotten this far. I would have just been so frustrated and disgusted and upset. So I think, I don't know. I don't think I gave you any solutions because I don't have them, but I would say that there's a reason why you don't see a lot of students of color in subspecialties, and also I would say there's a reason why you don't see a lot of subspecialists of color researching disparities.
Right.
It's really, yeah.
Yeah. I would just say that actually you did offer a solution. Because, I mean, it really speaks to systemic structural change within our medical education and within our, actually just within academia itself. How we choose to reward moving along the tenure track, if you will. How that needs to include, be more holistic, to be able to bring in people with different perspectives. And support those different perspectives. I mean, we're talking about going through a paradigm that is really, it's just, it stems from white supremacy. I'm just going to say it. So we need to acknowledge that, and we need to talk about how we reframe, restructure to undo that. I mean, that's really what we're talking about. It's hard work. But I think we are starting to do it. I mean, we're starting to do it with Janice's work with respect to training clinicians about implicit bias. We're starting to do that with respect to incorporating diversity exemplars in APT criteria. We're doing that in nursing. I mean, it's not across the board everywhere, but it's starting to happen. There are solutions. It's messy, and it takes work, and it takes persistence. But I think it's possible.
We have time for, you have a comment, just to follow, yeah, go ahead.
Well, I would just like to say it also takes will from the top down and accountability. And so, you know, it's really important when you think about 5.1% nationally underrepresented minority faculty in medicine. Something has to change. It's a pipeline issue. Subspecialties are almost entirely white, so developing a diverse applicant pool is not possible now, but it has to be accountability over time, top down, and everybody has to participate.
I have time for one more question here. Sure.
Yeah, my name is Mayan. I'm epidemiology, School of Public Health. I'd like to return just briefly to the idea of race as a construct in research. So we have one person who said we should deconstruct this idea of race. And it's something I've been thinking quite a lot about in my own work. And the question is, race is this aggregate measure, it's like a proxy. It stands in for a lot of other things. And one of the things that it stands in for, a lot of subcomponents though, is sort of this longitudinal exposure to bias, to aggression, to racism, etc., within this country, abroad, etc. So my question is it important as we start to examine new ways to define individuals in our research to try to maintain some of these longitudinal factors and other components that go into this very big category of race, this construct? And is it possible? Should we be doing it? And are there ways that you all think we should start approaching this issue? Thanks.
Okay, come up here. Sorry.
Yeah, the only way I can think about it is, is to appreciate the Black experience. And that's a historical construct as well. So how I deal with that is, like, if it's race over the long term, then everything needs to be looked at from a life course perspective. So that's how I frame my work. That I can't use race just as a control variable. I had to deconstruct it because it means so many different things in so many different contexts. And so to be able to do that, I have to take a lifespan, an intergenerational approach to research. So I think that's my homage to how to deal with to race in research.
I think that's absolutely what we need to do. And with respect to describing your models, I mean, I think you can start to do that. Taking more than just a sentence to describe what race is or how it's measured, you need more than that. And to be very intentional about how you think about it. I mean, I'm thinking regression models in my head, you know, so I'm thinking about what are the variables that are in my models and how do they influence the interpretation of the race covariate that I have? And then what are the implications for that for my findings? I mean, that's where we need to go, and I think we haven't really been trained to do that, but we need to be as epidemiologists.
So thank you so much for a wonderful panel. Before you leave, I have an announcement. So we're going to be taking a lunch break from 12:35 to 1:45, and those lunch breaks will be on your own arrangements, but there's really great places if you're from here. You know, the hub's downstairs. There's a lot of great things to eat there. If you're not from here, hub's downstairs. Another really great option is a quick short walk from here is in the Henry Art Gallery. The City Grind Cafe is really great, has really great eats. So, but please come back because we still have another panel, and of course our keynote speaker who will be speaking, and we also have a reception. So we want you to come back, and please be here promptly at 1:45 so that we can stay on time. I want to thank the panel for a wonderful